Treatment of anterior instability of the shoulder is a controversial topic that often requires surgical intervention. Advances in arthroscopy have enabled us to better visualize and understand the pathology involved. We can now tailor our surgical approach to the degree of capsulolabral laxity, anterior bone loss, and the size of the Hill-Sachs lesion. We have learned that recurrent instability is directly related to the amount of anterior bone loss, and preserving bone is imperative in repair techniques. We present our preferred technique for the management of bony Bankart lesions utilizing a transosseous repair. Here we are viewing a left shoulder from the posterior portal. The humeral head sits anteriorly and inferiorly from multiple traumatic dislocations. It is easy to appreciate the large patulous anterior-inferior capsule as well as the orange staining of the capsule secondary to recurrent hemarthrosis. Note is also made of a chondral loose body that sits in the axillary pouch. The remainder of the superior and posterior labrum is intact. As the humeral head is elevated, anterior bone loss is appreciated. There is a small, shallow Hill-Sachs lesion present on the posterior aspect of the humeral head, and the undersurface of the rotator cuff is intact. The anterior-inferior portal is established utilizing an inside-out technique by palpating the superior edge of the subscapularis and utilizing a spinal needle to ensure adequate access to the inferior aspect of the glenoid. This is followed by a standard metal cannula, which is subsequently dilated up to an 8 mm cannula. Once the cannula is inserted, a probe is used to palpate the bony Bankart to help judge the size and mobility of the bony fragment. An anterior superior portal is created in a similar fashion by palpating the anterior edge of the supraspinatus and utilizing a spinal needle to confirm appropriate access to the inferior aspect of the joint. This portal will be employed for viewing during the majority of the case. A metal cannula is inserted from the posterior portal to assist in estimating the amount of bone involved in the Bankart lesion. By measuring from the central barrier of the glenoid, it is evident that the bone involvement is less than 25% of the glenoid width. Attention is then turned to freeing up the bony Bankart fragment, which is healed medially to the glenoid. An arthroscopic liberator is useful for separating the two fragments. The shaver is used to remove all soft tissue in an effort to maximize bony surface area. The bony fragment is probed to assess size and mobility. The fragment must be mobilized above the glenoid face to achieve adequate exposure for drilling. The glenoid is also assessed for anchor placement and fragment reduction. A burr is then utilized to freshen up the bony surfaces in an effort to optimize healing. Again, the fragment is assessed for mobility as the grasper is brought through the anterior-inferior portal. The posterior lateral capsule is palpated in preparation for inferior anchor insertion. A spinal needle is again utilized to confirm adequate accessibility to the inferior glenoid. A percutaneous entry is established for the anchor guide. The guide is placed at the glenoid edge, taking care to optimize anchor placement. The appropriate angle is maintained and standard drilling and anchor insertion is carried out. An 8 mm cannula in the posterior portal is used to pass the initial inferior stitch. Great care is taken with the first pass due to the proximity of the axillary nerve to the inferior capsule. The first suture pass facilitates reduction of the inferior capsular volume. A bite of the inferior capsule is taken, and the suture passer exits just inferior to the labrum. A standard shuttling technique with a PDS suture is used to pass the first suture back through the capsule. The second suture pass is taken from the anterior-inferior portal. This pass will continue to reduce the anterior-inferior capsule and shift the tissue superiorly and laterally. Here you see the two stitches passed in a simple fashion. These are left untied so as not to impede the mobilization of the bony fragment. A spinal needle is again utilized to localize the trans-subscapularis percutaneous approach for the second anchor placement. The drill guide is placed on the subchondral bone to ensure that the anchor placement will be parallel to the drill holes in the bony fragment. The fragment is again mobilized in preparation for drilling. A long drill guide is brought in from the posterior portal. Care is taken to ensure that the drill holes are at the same depth as the anchor in an effort to achieve an anatomic reduction of the bony fragment. A 1.6 mm guide wire is drilled through the bony fragment and visualized on the anterior side of the capsule. This is followed by a standard 5-inch spinal needle, which is passed through the drill hole and again isolated on the anterior aspect of the capsule. Once this is accomplished, a nitinol suture passing wire is passed through the spinal needle and retrieved out the anterior-inferior portal. The spinal needle is removed, and the nitinol wire is used to shuttle the first suture through the bony fragment. These same steps are repeated for the second suture, and the two sutures are now in position to secure the bony fragment. Due to the small size of the bony fragment, we elected to remove the second suture from the anchor prior to tying. The third anchor is placed just above the bony Bankart fragment to further secure the repair. Two additional stitches are passed in a simple configuration, and the knots are now tied utilizing standard suture management and arthroscopic knot tying techniques. Here you see the final repair from the anterior superior portal and the posterior portal as well.